This conference will now be recorded.
Good morning, everyone. Today, our topic of discussion is peripheral neuropathies. So, you are all know about the peripheral nerves in central nervous system. Central nervous system constitutes of brain and spinal cord. The other nerves all are peripheral nerves. So, most peripheral nerves are mixed and they contain sensory, motor, and as well as the autonomic fibers. Nerves can be subdivided into three major classes. Those are large myelinated nerves, small myelinated nerves, and the small unmyelinated nerves. The motor nerves are all large myelinated nerves, and the sensory nerves are large fibers, which contains large myelinated nerves, which carries proprioception and vibration. And small myelinated and unmyelinated nerves carries pain and temperature. So peripheral neuropathies are classified into mainly three types based on the part which is affected. So if the cell body is affected, it is called as neuronopathy or ganglionopathy. If the myelin is affected, it is called as myelinopathy, and axonopathy if the axon is affected. So in peripheral nerves, there is a root from which the spinal cord originating point. So it is called as radicle also. So if it is affected, it is called radiculopathy. So what are the hereditary peripheral neuropathies? Charcot-Marie-Tooth is the most common hereditary peripheral neuropathy. Fabry's disease, adrenoleucolytic dystrophy, Tuftson's disease, Tanger's disease, porphyrias, and familial amyloid polyneuropathy. So most of these are metabolic diseases which affects the peripheral nerves. So acquired peripheral neuropathies. Primary are AL amyloidosis and diabetic neuropathy. So diabetic neuropathy is the most important. Nowadays diabetes is more common. So in diabetic neuropathy, there are different types of neuropathies based on the involvement of peripheral nerves of different sites and the pattern of peripheral neuropathy. So the first one is diabetic distal symmetric sensory and sensory motor polyneuropathy. Means the distal most parts are mostly affected, which are symmetric, involved symmetrically bilaterally. They may be sensory or sensory motor polyneuropathies. These are slow in onset, progressive. It depends on the degree of diabetes control and glycemic control. Mainly depends on the degree of duration of the diabetes and degree of diabetic control. And diabetic autonomic neuropathy, which involves autonomic nerves. Mainly different systems are involved in this autonomic neuropathy, like CVS, which causes postural hypotension and resting tachycardia, silent MI. So in GI, gastroparesis, vomiting, nausea sensation. So these are the autonomic symptoms of GIT. And in if we come to the urinary system, difficulty in micturition and ejaculation problems, erectile dysfunction, these are the common symptoms. And there may be a hypoglycemic unawareness due to autonomic neuropathy in diabetes. So these are the symptoms of autonomic neuropathy in diabetes. And the diabetic radiculoplexus neuropathy, which is also called as diabetic amyotrophy or Bruns-Garland syndrome. This is of slow onset, but it will be severe, somewhat severe than the DSPN. And there is the diabetic mononeuropathies or multiple mononeuropathies, which is also called as mononeuritis multiplex. So in diabetic mononeuropathies, only single nerve is involved. In multiple mononeuropathies, more than one nerve is involved. And diabetic mononeuropathy, single nerves like radial nerve and femoral nerve and peroneal nerve. Those are involved. In radial nerve, they can cause wrist drops, and common peroneal nerve involvement causes foot drop, like that. So other acquired neuropathies are polyneuropathies are hypothyroidism, Sjogren's syndrome, rheumatoid arthritis, SLE, scleroderma, multiple connective tissue disorders, sarcoidosis, hypereosinophilic syndrome, celiac disease, inflammatory bowel disease, uremic neuropathies, and chronic liver disease, critical illness polyneuropathy. These are all the acquired neuropathies. So next one is infectious peripheral neuropathies. So the infectious peripheral neuropathies may develop due to subacute or chronic infections like Hansen's disease, Lyme's disease, diphtheric neuropathy, HIV related. HIV can cause different types of polyneuropathies, and different nerves are involved. It depends on the stages. And herpes zoster virus, cytomegalovirus, Epstein-Barr virus, and hepatitis virus. So infectious, these are the infectious peripheral neuropathies. So coming to neuropathies also associated with malignancy. So mainly the malignancy causes metastatic lesions, the on-site lesions, which may involve the peripheral nerves, that causes neuropathies, like paraneoplastic sensory neuropathy or ganglioneuropathy, neuropathy secondary to tumor infiltration because of the tumor mass, and neuropathy as a complication of bone marrow transplantation, lymphomas, and multiple myelomas. So coming to nutritional neuropathies. What are the nutritional neuropathies? We all know that vitamin B12 deficiency causes neuropathies. In between B12 deficiency, large fiber sensory loss mainly affects the proprioception and vibration, with sparing of small fiber modalities is present. So if there is any sensory ataxia, we can diagnose it by the unsteady gait. So diffuse hyperreflexia and absent angle reflexes are seen. Full clinic, actually in vitamin B12 deficiency, there is subacute combined degeneration is seen, we all know. But actually complete picture of subacute combined degeneration is not that much common. So it's only a part of the symptoms of SACD are seen. Okay, then coming to thiamine deficiency. In thiamine deficiency, generally there is a mild sensory loss and burning dysesthesia in the toes and feet, and aching and cramping in the lower legs are seen. Pain may be predominant symptom in the thiamine deficiency. With progression, patients develop features of non-specific generalized polyneuropathies, with mainly involvement of the distal sensory loss of the feet and hands. Okay. In vitamin E deficiency, what are the features of vitamin E deficiencies? In vitamin E deficiency, there is insidious onset of symptoms are seen, and the progression is very slow. In vitamin E deficiency, there is spinocerebellar ataxia and polyneuropathy, manifests progressive ataxia, and signs of posterior column dysfunction are seen, such as impaired. We all know that posterior column dysfunction causes impaired joint position and vibration sensation, and there is hyporeflexia is seen, but plantar may be extensor due to spinal cord involvement. In vitamin E deficiency, the spinal cord involvement is there, so plantar may be extensor. In vitamin B6 deficiency, there is non-specific manifestations as a generalized axonal sensorimotor neuropathy. So axon is involved in this, and sensorimotor polyneuropathy is seen. So next, coming to the up to now these are the vitamin deficiencies, and then coming to micronutritional deficiencies like copper deficiency. In copper deficiency, there is lower limb paresthesia, lower limb so lower limb tingling sensations, weakness, spasticity, the stiffness, and gait difficulties are seen. Large fiber sensory function is mainly impaired. The reflexes are very brisk and plantar responses are extensive.
क्या रखे चलते हैं वीडियो क्या रखे पूरे हो रहा